Welcome to our global audience. I'm Eylem Taşdemir, Senior Program Officer at Columbia Global Centers Istanbul, one of 9 centers across the globe established by Columbia University to connect the local with the global, to create opportunities for shared learning and to deepen the nature of global dialogue. Today, we are delighted to host this online panel in collaboration with the Columbia Global Centers Rio. Now, I would like to introduce our moderators, Dr. Özge Karadağ-Çaman, Public Health Researcher at Columbia University, and Dr. Yanis Ben Amor, Executive Director, Center for Sustainable Development at Columbia University. Thank you for joining us.
Thanks so much, Eylem. Hello, everyone. So my name is Yanis Ben Amor. I am the Executive Director of the Center for Sustainable Development at the Earth Institute at Columbia University. The Center for Sustainable Development is the co-host of the Secretariat of the Lancet Commission on COVID-19. And it's my pleasure to be co-moderating this event today with my colleague, Dr. Özge Karadağ-Çaman. We have some changes to report. Unfortunately, our colleague from Brazil was not able to make it, so we will have an extra 10 minutes at the end of the event for additional questions. Throughout the event, if you want to ask questions, there is a tab at the bottom of the screen for Q&A. So the chat box has been deactivated. You can ask any question. Please include a name and an affiliation, and we will try to answer as many questions as possible at the end. So after Wuhan, Spain, Italy, New York in March and April became the epicenter of the coronavirus pandemic, at least in the United States. So to help us understand how data played a big role in fighting the coronavirus pandemic in New York, I'm happy to introduce our first 2 speakers, Corinne Thompson and Matthew Montesano. Corinne Thompson is currently the Director of Epidemiology of Waterborne Diseases in the Bureau of Communicable Disease in the New York City Department of Health and Mental Hygiene. At the moment, she is activated for the DOH response to COVID-19, and she is a co-lead for the Epidemiology and Data Unit. Prior to this position, Corinne earned her PhD from the London School of Hygiene and Tropical Medicine, where she studied the epidemiology of pediatric dysentery in Vietnam. She also has an MSc from the London School of Hygiene and a BS in biology from Penn State. And Matthew Montesano is a data communication specialist with the New York City Department of Health and Mental Hygiene, whose work focuses on synthesizing research from health communications, user experience design, and data visualization to communicate public health data in ways that are clear, useful, and equitable. Corinne and Matthew, the virtual floor is yours.
Great, thank you, Dr. Ben Amor. As mentioned, my name is Corinne Thompson, and I'm here at the New York City Health Department. And I just want to thank Columbia for the opportunity to chat to you all this morning. And before I get started on the details, I just wanted to acknowledge that I represent an exceptional group of dedicated problem-solving, mission-oriented people whose work is often underappreciated here at the Health Department. And we've been working tirelessly since January to try to get the data in shape to the point where we trust it and we can communicate about it. And for the other public health professionals on the phone, I'm sure you can empathize. So as Dr. Ben Amor mentioned, New York City was the first large jurisdiction in the US to have an explosive outbreak of COVID-19. And we needed to make rapid decisions that had pretty dramatic implications for understanding the spread of the epidemic in the city, which has a population of about 8.5 million people. Data sharing was included as part of that discussion pretty early on, as everybody was looking to us to communicate what was happening. And there were so many unknowns in this particular outbreak that people wanted to fill in the gaps and understand a lot of these unknown parameters. And so first part of this talk, I'm just going to give you an overview of how New York City does surveillance for COVID and briefly go over the epidemiology of the virus in our jurisdiction using our public-facing webpage, which you can see here. So we don't have slides today. We're just going to actually use our webpage, which you can also access on the internet to talk through our data. And then data communication is something that my colleague Matthew is going to touch on in more depth. And primarily talk about how the pandemic is something that people understand through data, and how important communication was early on and continuing through the span of this epidemic, and how important trust is to get people to change behaviors, as we were asking them to do in a pretty dramatic way. We needed people to trust us. So before we talk about data communication, I just want to talk about how how surveillance data works in New York City, and point out some important caveats that are necessary for interpreting our data. So electronic laboratory reporting is the mainstay of our disease reporting system. So anytime someone is diagnosed with COVID-19, it is required by law to be reported to the New York City Health Department. Testing, as if you recall, was super limited really early on. So our first case was diagnosed on February 29th. But we had been screening for cases from about the end of January. However, because CDC was the only testing laboratory in the country, the testing criteria were really strict. So we suspect that there were many cases probably circulating in February, but they didn't meet the really strict criteria at the time. And then actually through May, we were telling people with mild or moderate symptoms to stay home and not seek testing because we were running out of PPE and we were running out of testing supplies and materials. So especially in the first 3 months of this epidemic, a lot of the data is representative of very severe hospitalized cases, which has, impact on the types of trends that we were seeing. In terms of surveillance, we had started with interviewing every case, which is where we would pick up the phone and ask them a whole bunch of exposure questions. For example, had they traveled to Wuhan? But we quickly shifted to prioritizing hospitalizations, and then from there, persons who had died. And then by probably the end of March, we were interviewing only patients or interviewing next of kin of patients who had died who were under the age of 65. So we moved very quickly from trying to get as much information as we could on every patient to being totally overwhelmed with that, and then just trying to maintain our basic electronic disease reporting system. We have therefore really limited information on each case, and this was a very challenging thing to communicate as people from our own government to the public to news agencies expect really complete timely data, and they wanted that to be made publicly available very quickly. And surveillance data is unfortunately just very messy and takes some time and some nuance when explaining it. So now I just want to go over the web page at a kind of high level. So if you can see here, this is our public-facing web page, which we're very proud of. We update this every day, excuse me, with data from yesterday. So these epicurves you can see here, this is the case epicurve. So this is by date of diagnosis. You can see we started to really ramp up the last week of March. First week of April was our kind of peak week for cases. And then since then we've been since about May, end of May, beginning of June, we've had a kind of consistent couple hundred of cases per day. Again, the testing patterns really changed throughout this time period. So now we started to see a lot more mild and moderate cases over the last month or two. And now our testing volume has gone up dramatically, which I can show you in a second. And then if you want to click on hospitalizations, this is our hospitalization epicurve, which is by date of admission to the hospital. You can see it follows a similar pattern to our cases. And then deaths, we have, this is by date of death, and you can see it shifts slightly to the right as people, once they are diagnosed, I think we had about a median of about 5 to 6 days before people passed away. So at the moment we have 218,000 cases since February 29th. We have about 56,000 hospitalizations. And then we have close to 19,000 confirmed deaths, which is where somebody had a PCR positive COVID laboratory test. And we have about 4,600 probable deaths, which is an instance where someone has a COVID-19 or something similar listed on their death certificate, but they did not have, either had a negative laboratory test or did not have a COVID laboratory test. So if we scroll down, I just want to show you one of our most popular elements here has been the map. So this is a map of cases by zip code in New York City. So there are 177 zip codes, and this is cumulative data since the beginning. And the darker the color, this is case rate here. This is the case rate per zip code. And you can see very clearly, if you scroll over, one of the handy features of this map and to communicate data, which Matthew will talk about later, is if you highlight each zip code, you can check out individual, you can see the zip code number, the name, and the metrics of interest for each zip code. And we found that people really enjoyed being able to see their neighborhood on a map. And for those of you who don't know anything about the geography of New York City, you can see very clearly that there's a kind of a cluster in Matthew, if you can circle in Elmhurst and Corona and Queens. And this is an area that was heavily hit early on. And then we also have kind of more general clustering in the Bronx, which is up in the northern area. And this has been also a consistently high burden area. And we have what are called radio buttons, so that you can click through. So if this is, yeah, that was case rate, this is case count. So again, a slightly different type of visualization. So as epidemiologists, we always like to communicate rates, but we found that people really, especially journalists, they really like counts because it's very easy to understand. So we're trying to make different types of information available. And then we also have death rate, confirmed death rate, a similar type of pattern, and then confirmed death count. And then finally, we were using percent positivity pretty early on. And the reason that this is the numerator here is the number of people who tested positive, and the denominator is all people tested per zip code. And this was a little bit tricky to communicate at first, but the reason that we wanted to use percent positivity was it got around issues around access to testing. So we found that some neighborhoods had low case rates, not because they had low transmission, but because people had a difficult time accessing healthcare and accessing the testing. So percent positivity was a way of trying to better understand where is transmission actively happening now. And then just one more thing I'll say about this is there's also a table element here that we found people really enjoyed. So this is a tabular format. So if you wanted to search for your own neighborhood, you can, or search, yeah, this is looking at zip code only Brooklyn. You can search for the information that way. Then we have, just want to go over syndromic surveillance. So this is emergency department visits and admissions for COVID-like illness. So this is one of our kind of early warning signs. So you can see here to the far left, we were coming off of the tail end of influenza season, and one of our main concerns was we would be unable to distinguish between flu and COVID. But luckily for us, the flu season ended right before COVID really started to take off in a big way. So once we start to see increases in admissions or in visits and admissions, we're not sure if these people necessarily have COVID. Often they do not have a positive lab test, but this is an early indicator that we have an issue. So we're continuing, we watch this very, very closely to monitor for our second wave, which we think is probably in the future, fortunately. And then next up we have our testing. So this is percent positivity citywide. So we're using this as a metric. And I think a lot of jurisdictions in the US are using this as a metric to understand the severity of the epidemic over time. And so at some point you can see we were over at about 70% of our tests were positive. Again, the availability of testing at that time was much more limited than it is now, but you can see now we're at about 2% positivity. And then just to show the number of people tested, people really are very interested in this. And so you can see here that the dark blue line is the number of people who are tested over time. And then the light blue line at the bottom is the number of people who are positive. So we've really dramatically increased our testing capacity, which is great. And then the number of people who are positive is lower. And then the last thing I'll say here is the case hospitalization and death rate. We found that people want to know a lot about the demographics of each of our patients generally. So we have, for a number of different types of demographic information, we have case rates, hospitalization rates, and death rates, particularly for age, which at the beginning we felt was probably a risk factor, but now we know is a risk factor. Race and ethnicity. Unfortunately, our race and ethnicity data is pretty incomplete for cases, but we put it up anyway because of the importance. But if you look at hospitalization and death rate, you can see very clearly that Hispanic and Latino, as well as Black African American New Yorkers, are far more likely to have much higher rates of hospitalization and death. And then we're lucky in New York City, we also routinely report out by neighborhood poverty level. So we can look at neighborhoods of low poverty, residents of neighborhoods of low poverty compared to residents of neighborhood of high poverty, and see a very stark increase in rates of disease, hospitalization, and death, which we found was very important to communicate early on. And then just to mention only, we have a lot more information on this webpage. We encourage you certainly to go and check it out. And we also can there's an ability to download this information, which we found was very, people really like that. And then just to summarize my portion of this, the epidemic, where we are right now in New York City, unlike the rest of the US, we actually are in a lull period between wave 1 and wave 2. Again, we've gotten our percent positivity down to about 2% citywide, and we're tracking emergent spatiotemporal clusters by looking at neighborhood percent positivity in real time. So we're trying to kind of deploy resources in real time to areas that we think are concerning. We do expect a wave 2. We know that social distancing is really what drove down the sharp decrease in cases. So we're monitoring very closely for reemergence, especially given the increasing incidence nationwide. And we do expect that the data needs and communication needs will be slightly different for wave 2 as we know more about this virus and how it impacts our community. So we're always thinking on how we can improve our public-facing data page. And with that, I will turn it over to my wonderful colleague, Matthew Montesano, who has been the main force behind our data visualization.
Thank you so much, Corinne. And thank you to our hosts for having us and to all of you on the other end of this broadcast. Thanks for joining us. Corinne did a fabulous job of summarizing some of the complexities of the whole data environment ecosystem, the demands and needs. And as she said, I'm going to focus a little bit more on the challenge of communicating it. And I want to get into this by thinking really big picture. Now, this pandemic is something that people have understood through data, something that we all understand through data. I say this not as a data scientist, not as a public health professional, but as a person, a member of the general public. Because while data are useful to public health professionals, policymakers, academics, researchers, infectious disease modelers, and so on, throughout this pandemic, ordinary people have paid attention to data, to case counts and epi curves. We were trying to make sense of the unknown, trying to understand the danger it posed, the extent to which we're at risk. And one's sense of being at risk is a key component of health behavior change. Several theoretical models that guide health communications are frameworks based on balancing an accurate sense of risk with a realistic belief in one's ability to protect oneself from that risk. An accurate sense of risk. That means that people needed to trust what we were saying about whether and how much risk they were at. We needed them to trust us, and we needed to earn their trust. In this pandemic, the changes we are asking people to make, these have been so significant. Stay home, take your children out of school, give up your job, maybe. Take on one risk to deal with another one. This is a huge ask. So how do we earn people's trust so that they will make the changes we ask of them? We earn their trust with clear and easy to understand information. When we speak the language of the people we're trying to meet, when we meet them where they are. These are things that I learned as a community organizer a long time ago. Information, data isn't neutral. We know that people don't just believe facts because you tell them facts. People don't just change their behavior just because you tell them what's healthy. People don't just slow down because you put a speed limit sign on the road. And similarly with data, people don't learn, understand, or use data just because you throw numbers at them. Information uptake is affected by the information itself, the format in which it's delivered, and the medium through which it's delivered. This is the full information environment. So we had important data and we wanted to deliver it in formats that could be widely accessed, understood, and used. Corinne gave an overview of what our data say, and you saw the platform on which we set it. I'm going to give you a little bit more information about the tools that we use. Ultimately, we built a system that is fairly low tech, easily replicated, and based on free and easy to use tools that require very few specialized skills. It allowed us to build a product that helped our data become more trusted and more widely used. And it let us do this fast. So the first tool that we used to create the charts that you saw on that page is a tool called Data Wrapper. It is a product that's built mostly for journalists, not developers. It focuses on providing the ability to rapidly develop and deploy visualizations that have strong communicative or explanatory power. And so this let us create interactive data visualizations that we can embed in any ordinary web page. It's so simple. We upload our data, we select some options to design the charts, and we click publish. And the tool itself generates a few lines of simple code that we just drop into our web page to embed the interactive visualizations. It's also mobile compatible and responsive right out of the box, and it can be built to meet accessibility requirements to ensure that people with disabilities or different needs can still access this information via keyboard navigation or via screen readers. And this is an important component too. So we built all of these useful charts and maps, but we also needed a way to feed them data and update them every day. And for this, we used GitHub. Now, GitHub is a service designed to help people store and collaborate on code and software projects. It's powered by software called Git, which manages version control. We used it in a relatively simple way. we uploaded our data as CSV files, comma, separated values files, into a public repository, basically a folder on the internet. We told the data wrapper charts to read the data that we stored on GitHub, and this made it very easy for us to make daily updates. We just upload new data every day. And when we upload new data, the charts refresh with the new data. But more importantly, it helped us make our data available for download, which is something that Corinne touched on. People can go to the GitHub repository and quickly download those data and use those CSV files, which are machine readable right out of the download. It also offered a platform where other users can engage with us and ask questions via some of the other features on GitHub. And we could also offer them documentation. In our GitHub repository, we have 14,000 words of metadata, documentation, that power users can use to understand the data, some of our methods, some of our caveats, limitations, strengths, all of that. So it was a very powerful tool for furthering the use, engagement, and understanding of the data. Now, the big picture about both of these tools is that they're fairly simple to learn and use. They're also free. They simplified our workflow. Like I said earlier, in order to make daily updates, we just upload a fresh batch of files to our GitHub repository. It overwrites the old ones, and all of the charts on our website update. These two tools are fairly common and widely trusted. They're open source, they're popular with the technical community, even though they're simple. But most importantly, they enabled us to publish fast and accessibly in a way designed to communicate. Our ordinary users got clear charts on a website instead of information buried deep in PDFs. Power users got machine readable downloads, a ton of documentation and metadata, and the ability to ask us direct questions about the data. This builds the trust that we need. I think this was successful. During the pandemic, our department's web traffic skyrocketed. We saw web traffic that was 10 times higher than before the COVID pandemic. And over half of this web traffic was to just a few web pages about the data. This showed that there's a huge thirst for this information in this moment. And we think that providing it in a way that was helpful, accessible, and easy to understand, we think that this helped us serve the public. And it also helped our colleagues outside the agency working alongside us in this pandemic. Ultimately, ensuring that the use of data increases the power of the data. To any public health professional, that's a very good thing. Public data belong to the public, and it serves them best when we make it easy to access, easy to understand, and easy to use. Thank you.
Hello again. Our next speaker is Professor Banu Çakır, and I would like to introduce her first. Professor Banu Çakır graduated from Hacettepe University's Faculty of Medicine in Ankara, Turkey in 1989. She obtained an MPH degree from Emory University in 1996 and a PhD degree in epidemiology from University of North Carolina at Chapel Hill in 2000. She also completed a medical residency training in public health at Hacettepe University Faculty of Medicine. Professor Çakır has been working at Hacettepe University since 1990 with a sabbatical period in 2008 to 2009 for work with WHO as a National Program Officer for Non-Communicable Diseases in Country Office, Turkey. She is responsible for the graduate program in epidemiology and the epidemiology section of the MD PhD program at Hacettepe University. And she has around 100 papers published in peer-reviewed journals. So I also would like to remind you that you can send your questions to the Q&A section while Professor Çakır presents. So please, I would like to give the floor to Professor Çakır. Thank you.
Before starting, I would like to emphasize something that I'm working with a university hospital, although I have connection with the Ministry of Health. Today, whatever I will present today is used based on the shared data of the Ministry of Health. So I'm sure that there's so much else to share, but I'll try my best with whatever we have publicly available. We are in the midst of a still evolving pandemic. All of us are working very hard, but we are complaining often that things are not going right, and we are all seeking for more effective management plans. I understand that effective health policy plans are hard to be established in such a rapidly changing environment, and the formulation of health policies for successful management of a pandemic is a complex process, often under the pressure of scientific, social, economic, and political forces. Well, of course, you can read the statement in an inverse manner nowadays. Scientific information is evolving. If you check LitCovid webpage today, the information is huge. But it's usually uneven in quality. The findings are often not conclusive, and from the policy makers' point of view, it's often inaccessible and it's too complex. So what we need is a good communication and interaction between scientists and policymakers. And if you cannot do that, what is ultimately happening is that the policy decisions are being influenced by policymakers' own values, priorities, and competing sources of information, including the anecdotal and personal experience of many of our health professionals that we have been watching on TV for quite some time. So talking for data is crucial. For better understanding, efficient control, and reliable forecasting of the pandemic, but which is also it is also crucial for evaluating the effectiveness of various interventions. We use data for international comparisons, not to see the big picture and the progress, but also to identify the best practices that we can also use for our own communities. And lastly, but not the least, we have just heard about New York example. Data is crucial for convincing people, the general public, that the COVID-19 is a real pandemic and we should combat with it. So what I believe is actually talking with data is the only way that we can use for effective and long-lasting interaction, communication, and trust between all three parties, the scientists and policymakers and the general public. I cited here a recent publication of myself about our experience with COVID-19 in Turkey. I believe it could be interesting for especially our audience from developing countries, especially if they still have a low number of new COVID cases. Well, we say that it's important to talk with data, but of course you need data. This is our main source of data starting from the first day of COVID-19 epidemic in Turkey, which was the March 11th. And this table of daily coronavirus status in Turkey, I put it in Turkish. We are so familiar with it, but let's go through it in English. On the right side of the screen, we have the total number of test numbers. We have the total number of daily new COVID cases and the total number of daily new deaths. And on the left side, this is pretty much, this was from the March of 27, the third week of epidemic in Turkey. So the numbers were slightly low at that time. On the left side, we have the total number of tests. These are all PCR testing. In Turkey, whenever we say a case of COVID-19 or a death, it's all PCR confirmed cases and deaths because the others are not being reported currently. We have the cumulative number of tests, cumulative number of cases, cumulative number of deaths, and cumulative number of individuals who are reportedly recovered at that day. We have two numbers here, which we usually use as a surrogate measure for the severity of disease in Turkey. The first one is the number of patients currently in ICU, and the second number is the number of individuals who are intubated for that particular date. This is similar to what we have seen with New York example. We have the number of tests increasing over time, and we have the number of test positivity. Again, similar to New York experience, we had, first of all, test positivity going up to 26-28%, and nowadays it's stabilized around I can't see my own taste, around like 3 or 4% daily. And this is our curve. As you see, we had the peak value around mid-April, a month after the initiation of the pandemic in Turkey, and numbers went consistently down. And you see 3 arrows here, and those are the initial dates of our normalization steps. As of July the 1st, we are almost totally normalized if you put aside the social distancing, masking, and hygiene. And you see each time we have the measures released, we have numbers going up again. And this is the case doubling time, which we are using as a measure of the progress of COVID pandemic in Turkey. I would like to share this slide for a couple of reasons. The first thing is that this blue line here is the case fatality ratio, which was almost consistent over the last 4 months. It has never been above 3. But as you see, starting from the initial steps of normalization, we had a huge increase in the number of individuals being in ICU, and this could be a presentation of more elderly people being socialized after 3 months of stay-at-home orders, and this could be explained by those. But as you see, the percentage of individuals who are intubated is not increasing that much. So this could be actually an apparent presentation of the preference of the clinicians to have their patients in ICU rather than in ordinary inpatient clinics. Here you see 2 curves. The first one is the distribution of new COVID-19 cases over time, and the green trend is for those who are recovered, and you see those trends are mimicking each other, which is something we expect, and the time lag between those two, about like 2 or 3 weeks, is something we expect for between the infection and recovery. What is hard to understand is those spikes, so we need to go and check those the reasons for those spikes here. But what is more interesting for me is these blue bars. These are the distribution of COVID-19 deaths. It mimics very much the distribution of the cases. This is expectable, but they are so close to each other. I heard Corinne saying that there's a 5 to 6 days of a lag between, I guess, the hospitalization and deaths, but this is between the diagnosis of infection and death. So one option could be the fact that maybe admissions are too late, so the timing between the infection and death is close. Or the other thing is that given our low case fatality ratios, probably our clinicians are doing a good thing, successful thing, just to helping those out to get recovered if they survive long. But again, this is not something expectable, so we need to work on it. This is our last situation with 220,000 total cases and 5,400 deaths. And we have as of the 18th of July, we have a total of 12,000 active cases. It is distributed throughout the country evenly. this is from April 17, when Istanbul was the epicenter. We have these maps from time to time, but we have a good mobile application that we can check through our phones on a daily basis and see on map which areas are more risky, as mentioned by red here, and the blue ones correspond to low risk areas, and the other parts are spared from COVID-19, at least reported COVID-19 cases. So individuals can go and check through their phones how risky their living environment or their vacation areas are. One new thing, starting from the July the 1st, we have weekly and daily situation reports provided by the Ministry of Health. You can check it through Ministry of Health webpage. We have English version available as well. What is new is the geographic locations, distribution by geographic locations of the incidence rates. And we have one more descriptive characteristics. We have distributions by age and sex, both for mortality and morbidity. Of course, these are good for public, but as scientists and as epidemiologists, we need further analysis of this data. Hopefully, by the time the national data is available, we will go and check for the risk factors of morbidity and fatality, and also will be able to evaluate comparative effectiveness of various non-pharmaceutical protective measures and off-label drugs in use, including their adverse effects, because we have no information about it for the time being. We all globally, I guess, have strong challenges ahead, so we need to collect more data regarding the long-term complications of this COVID-19, long-term immunity, if there is any. We have vaccine and drug trials in progress, so as epidemiologists, we need to go and check their data and try to interpret it from methodologic perspective. And what I find as a real challenge is we need to strengthen trust of individuals and scientists in science and evidence-based practice, so that we can get public trust as well to take more responsibilities and decisions. So my last slide will be on the collective efforts that I find necessary. We definitely need prospective cohorts on COVID-19 patients. If we can do it on a multinational, multi-center manner, using maybe similar study protocols, we will be hopefully more successful. I believe a multidisciplinary team effort is definitely needed, and this can only be reached by collaborative and coordinated efforts at international level, as this meeting today is an example of. In the meanwhile, we need to be ready for unprecedented twists and alternative ways out. Because so far this COVID-19 pandemic has surprised us in many different occasions. So I'm thanking all the audience for the attention, and to the Columbia University in particular for bringing us all together. Thank you all.
Thank you so much for your presentation, Professor Çakır, and thank you to Corinne and Matthew for their presentations. So we can now have the Q&A part. So I'm just checking the questions. Will the slides be available? Asked Olivia Carter Pocras. So the recording actually will be available online and shared with the participants, if that answers your question. And Stephen Alt said, great presentation, Dr. Çakır. How does Turkey report its data to WHO? What type of data and with what frequency? Do you find their cumulative multi-country data sets useful for your research and for Turkey's decision-making on COVID-19? So I think this question directly goes to Professor Çakır. I can repeat if you like. But yeah, the question is, how does Turkey report its data to WHO? What type of data and with what frequency?
Okay, thank you for the question. As far as we know, from the very beginning, actually even before the pandemic started in Turkey, in January, at the end of January, the Ministry of Health founded a large scientific national scientific board, including physicians mainly, from infectious diseases, public health, and chest diseases, and intensive care units, and so on. And they have started working with WHO country office, Turkey, which is also located in Ankara, Turkey. And they have been sharing their data with them frequently. And a couple of weeks ago, the head of WHO Europe for communicable diseases was here in Turkey, and we watched him on TV, not in person though. And what he explained is that they are having weekly to monthly phone meetings and sharing their data. And I guess this is a little bit more than what we see on public level. But at least what we have on web pages being shared with everybody internationally, starting from the July the 1st. Well, I find cumulative multi-country data sets really useful in the sense that it gives you a chance to see where you are in the country, and it's also important to see, say, how ranks differ from one place to the other. On the 11th of March, when we had the first case, we entered to these dashboards through the rank of, I guess, 52 or something. And within 1 month time, we were 7th in the most highest number of cases, and now we are about 15 or so. So these data sets are useful to see that everybody is going through the same way, and sooner or later we will have some surges in case numbers. But I find it more useful to use our national data for our decisions, because every country has different confounding factors like age and sex and like race and ethnicity and so on. So it is not really useful unless you have the whole line listing data from different countries so that you can do like modeling and so on. So I believe national data is more important in terms of decision making. My only concern is not to be able to see the whole data set. Hopefully we will be able to have our own studies in Turkey very soon, so that we can share our results as well. Thank you. I hope the answer is okay. This is all I had.
Thank you, Professor Banu. Okay, so I'm going to take the next two questions for Dr. Thompson and Mr. Montesano. So the first question is, there is a continuing rumor that all deaths now are counted as COVID deaths in the US. Can you speak as to how COVID-19 deaths are identified? And then the second question is, I noticed in the graphs presented by Dr. Thompson, there is a regular cyclical pattern in the number of tests performed. Is there any reason for more tests being conducted during certain days of the week?
Wonderful. Yeah, those are both good questions. I'll start with the second first, so because it's easier. So the cyclical nature that you see is due to weekends. So we see a really dramatic drop off on Saturdays and particularly Sundays in New York City, and this is actually consistent across the US as more jurisdictions are reporting their data. And this is for two reasons. One reason is people actually seek care less frequently on the weekends, and then secondarily, there's smaller clinics are often closed on the weekends, particularly Sundays. So you'll typically see an increase, a small increase on Monday as a kind of overflow of people who are seeking testing Sundays, but that definitely was a challenge to communicate. So we're working now to actually have a 7-day rolling average, because that and you'll notice that large media organizations also do that because it's easier to interpret. In terms of deaths, so I definitely don't think that all deaths are being classified as COVID. I think probably each jurisdiction does it slightly differently. In New York, I can speak to anybody who has a dative, or anybody who's registered as having passed away. With our Bureau of Vital Statistics, we do a match every day to understand. They have the kind of records of births and deaths in the city, and then we have the record of who was diagnosed. And so we match these every day to understand who has been both diagnosed and who has died. Since March 11th, I believe, was our first confirmed death. So that is how we classify confirmed deaths. So somebody who has a PCR positive test who's also died. And for probable deaths, it's a little bit more complicated. So we have to do a scan of the death certificate, and when they have COVID or something related to COVID on their death certificate, regardless of whether or not they have a positive test, we count them as probable. And then we report this information to CDC daily. So it's definitely been, the thing we're working through now is to try to understand if someone was diagnosed, for example, on March 20th, and then they die on June 18th, can we reliably say that that's a COVID death or not? I think we're now in the point of the epidemic where we're actually having to think about classifying people as are they specifically related to COVID or not? So there's a kind of national discussion going on about that at the moment.
And do you know whether this is a national way of doing it? Because I guess that the question is deaths in the US. And I know you speak on behalf of New York, but do you know whether other states may be doing it differently, where maybe there is a little bit of a question regarding deaths not being COVID?
I think probably there's something called the Council for State and Territorial Epidemiologists, so CSTE, and they typically will come out with case definitions. So there is a case definition for example, a case of COVID. And so I know that they're trying to define nationally standards for what is classified as a COVID death. I know that there might be some follow-up with this, so I can talk to colleagues who may know more, but I think it's the goal is at least to make sure everyone counts them the same way.
Thank you. You're next.
Yes, okay, no, I was just waiting if Matthew was going to answer or not. But yeah, there's actually a related question for Turkey. Does Turkey have a register of non-COVID tested severe acute respiratory syndrome cases? And if yes, does it show an increase in cases during the period of the pandemic?
Yes, thank you for the question. We have a very well-established influenza surveillance program in Turkey. We have a registry both for influenza and for other severe respiratory tract infections. It's the Sentinel surveillance program, and the specimens are collected from local regions and then are sent to two main centers, one in Ankara and the other one in Istanbul. And actually, why we are at least successful so far in this pandemic is because we had a very good influenza pandemic preparedness program, and this registry was part of it. So yes, we have some information coming from that areas as well. Well, we were lucky to delay the pandemic in Turkey through mid-March. So all these upper respiratory tract infections were actually low in numbers, but starting from September this year, probably we will have this problem. And from my understanding, the Ministry of Health has actually started a program to how to distinguish influenza and the other severe acute respiratory tract infections and COVID-19. And they have been becoming ready to make both tests simultaneously for all individuals. To my knowledge, there is no specific study to see how these test results were at the time of COVID-19, but I know that they are taking care of it. But I don't know the extent of it. I guess that's all.
Great. Thank you so much. Okay, I am going to combine two questions, and they're going to be for all three panelists because it has to do with the way that data is used by policymakers. So there is a question from Brazil. In Brazil, we do face the problem that the scientists and the political power are not talking in a good and regular basis. What are the measures to improve these communications in Turkey? And then there's also one that says, do you think our policymakers have actually taken data in their decision? So since Professor Banu just spoke, I'm going to give the floor to our colleagues in New York first.
Oh, great, thank you. Yeah, so it's a good question. We have definitely, you know, our relationship is good. I can say that the data that we've produced has definitely been used to influence how the city has rolled out resources. So we are doing right now, we're ranking each zip code on a routine basis in terms of most concerning to least concerning, combining some surveillance metrics, but also some metrics related to historical disinvestment to try to target neighborhoods, particularly that have, for example, low testing rates in anticipation of wave 2. So we're using what we know from wave 1, which is that primarily the kind of main story is unfortunately Black and Brown New Yorkers suffered much higher morbidity and mortality. And if we can target particular neighborhoods for prevention and outreach at the moment, to try to make sure that we can kind of mitigate such a severe outcome for wave 2. I think the city leadership has certainly taken that on board and is using our data. So it's definitely been challenging. I think epidemiologists speak one language, and I think policymakers often speak another language. So it's been a learning experience for me to try to translate epidemiological speech into actionable policy, something that policymakers can use. But I think now that we're 6 months in, we have a pretty good relationship. And I don't know, Matthew, if you want to speak on that.
Yeah, I'd love to just add to that. I think something that we've seen with the way we've made data available is that it's been particularly useful for media organizations. They've had a much easier time downloading our data and running their own analyses, finding their own stories in it. And that's really helped set the narrative around COVID-19's impact in New York City. The narrative and the reality that there are these incredible health disparities that have affected Black and Brown New Yorkers, as Corinne pointed out, and the narrative that this pandemic has not affected people equally. We saw those data on cases, hospitalization, and death rates by neighborhood poverty. So the fact that we were able to get these data into the hands of other people who will write about it and find stories in there and help take that narrative and further it, I think has helped really make sure that the data has affected a widespread public understanding and widespread public response.
Thanks. Probably I could add that in New York, we're very lucky because the policymakers actually from the very beginning, whether it's in the state of New York or the city of New York, believed that the threat was real. And so they were probably more likely to want to know the data and analyze the data and act on the data. Obviously, if the policymakers from the start do not think that, you know, coronavirus is a potential threat for the population, they may not want to act on that. Professor Banu, do you want to add something about Turkey?
My answer is yes and no. The thing is, I mean, I know that the policymakers, the Ministry of Health, and the President are working in very close connection with a group of scientists from different areas of expertise. But I don't know how much of that work really is presented on policy side, because, you know, we have talked today many times that this COVID-19 is not only a public health concern, but more of an economic concern. And the policymakers need to balance all those things, the social demands and the political concerns and the economic burden on it. So I have some experiences together with some policymakers. Although they believe and they do care for the data, they sometimes do their decisions based on some other forces. I guess this is inevitable, and it's true for all countries. But we are lucky in Turkey from a couple of different aspects, probably not being true for other countries, everything so far has been funded by the public, by the government. I mean, all testing, all medications, all hospitalizations, everything is for free for the individuals. So this is something good. Even if not everything goes with data, and even if the policies are not always in accordance with data, at least we have a chance to have free care. I mean, I guess it's very important and very crucial, and I hope it continues that way. So the answer is both yes and no. And I guess it will go that way. But if, as epidemiologists and other scientists, we continue to talk with data and to show how important it is to earn the trust of the public as well. So more and more the policymakers will go in that line as well. And one nice thing, I guess, is the proactive nature of the media people. We have talks on TV with different professionals every single day. Some of them are, individuals working with the public officers, and the others are not. So we have every different kind of ideas being presented on media. So I guess this is important from the public side as well.
Thank you so much. So we have another question. Olivia says, our county executive is using the fact that 40% of COVID cases are missing information on race and ethnicity as reason to not make number of cases and case rates by race and ethnicity public. What can we say to combat this perspective? Matthew, do you have anything to say or add to that?
I do. Yeah, thank you. I've got thoughts on that. Olivia, thank you for that question. I think this ties back to trust, which is something that I talked about earlier. If you don't give people the information that they want and they know that you have it, I think that harms trust, and it looks like you're covering something up if you're a public agency. If you have people's trust, they'll listen a little bit more to you, and you can explain the limitations. So I think in situations like this, it's important to put out data and say that it's incomplete. Say that it limits what we can generalize about it. It's important to lead these conversations and not dodge them, to enter into the conversation and help bridge that gap between agencies and the public, and hope that you can communicate the limitations of the data that you have. I hope that perspective can help, convince other decision makers that can help. And I think that Corinne might have some additional thoughts to add here as well.
Yeah, just from the epi point of view, we never have very good race and ethnicity data. It's just not a field that's particularly well reported to us, unfortunately. So it could be a breakdown of a patient goes to the doctor and reports their race and ethnicity, but then the doctor doesn't report that to the lab, or it could be that the lab does not actually report that information to us. So it's kind of it's a little bit of a difficult thing to explain to the public. So we have about 60%, I think it's about 60%. Excuse me, I think it was also about 40% of our race and ethnicity information for cases is complete, but our hospitalization and death information, race and ethnicity related to people who are hospitalized and people who have passed away, is much more complete. So we try to focus particularly on the kind of more severe end of cases, or the severe end of the outcome spectrum, because we felt more confident in that, interpreting those data. So they're kind of subpopulations, I would recommend using, like subpopulations where they're more complete. I recommend focusing on that.
Just maybe making a point about the question of race. So when it was reported, or when it is reported, that mostly, for example, in New York, it's Black and Latino communities that are most affected, there was a jump to a conclusion that maybe there were some genetic associations, when in fact it really isn't anything to do with the fact that maybe the African-American population or the Latino population is more susceptible to the virus genetically, more that when the rest of New York City was able to close down, shelter in place, and work from home, a lot of the essential workers were actually from the African-American and Latino community, so they did not have this privilege, let's just say that, to stay at home, and they were infected in bigger numbers. So I think it's important to note that it has nothing to do with genetic traits. Okay, so last question about serological testing. So just for the audience who may not be familiar, there are two ways to test. One is called PCR, polymerase chain reaction. That's how you test live virus, and you can test for active infection. Then you have serological tests that are blood tests, and there you look for antibodies, and that is typically a past infection. So the question is double. One of our audience members, Sanjali Mitra, is asking, is serological testing also being used to confirm positive cases in New York or elsewhere in the US? And I would want to add to that, how do you make sure that there isn't double counting? So for example, presumably in the early stages in March and April, when we only saw severe cases in the hospital, PCR tests were used, and there were not that many serological tests that were FDA approved. Now, when people feel more comfortable trying to test whether they had COVID, mild or asymptomatic, in April and May, they may go and get tested serologically, which should be reported to you. How do you make sure that there is no double counting? So these are the questions. Sorry,
Yanis,
this
would you like New York?
Yes, New York. And then,
Okay,
and then we
no
can go to Turkey. Sorry.
Yeah, no problem. So it's a really good question. So serology came online first at academic institutions in New York and then commercial labs. The first reports we had were about the beginning of April, but then the volume really started to pick up probably mid to late April into May. So we are collecting this information. We are not using it to confirm cases. So to be a confirmed case of COVID-19 in New York City, you have to have a PCR positive test. So we are starting to look at combining the data sets of serology and of PCR to understand the kind of trends and patterns. We are certainly looking at serology data, and we're actually hoping the next iteration of our webpage, we're hoping we'll have some serology data that will be available for perusing online for anybody who would like to look at it. So, but there are so many questions around serology right now. There's so many different types of tests, and there's so many potentially different antigens, and there's a real confusion as to what a positive serology test means. So at the moment, we're not folding it into any kind of diagnostic or confirmatory algorithms. But I know that there's a lot of work being done to try to understand a little bit more about what a result from a serology test means.
So there is a strong possibility that you are actually undercounting, because you started your presentation by saying that, by reminding the audience that in New York City, mild and asymptomatic cases were specifically asked not to get tested because there was just not enough capacity. So it is clear, if the serological tests are not being used to count retrospectively, you will be missing cases. Oh,
huge. Yeah, and that is a giant caveat that should always be used in interpreting our data. I would love to know what % of all cases we have diagnosed, but it's a giant undercount. That's correct.
And the problem is that now data seems to indicate that actually serological response will wane over time. So if you don't check them soon after the infection, so within maybe 1 month or 2 months, they may have had a past infection and they will go completely undiagnosed. Professor Matthew or Professor Banu, do you want to add something?
I have a, I'm sorry.
Sorry. No, okay, Matthew, it's your turn.
Okay, my small addition is that, as Corinne mentioned, while serological testing isn't being used to confirm positive cases in New York City, I believe that there may be some states in the US where that is happening. I'm not sure which one.
I think it's Florida, and I think it was an issue. I may be wrong, but I think it was an issue because they counted twice some people, and it ended up being an issue with the CDC. Okay, so maybe one final question in the interest of time.
Can I add something?
Sorry, yes, of course, Professor Banu.
Well, maybe just to make sure that I understand the question right, actually serologic testing is not to confirm positive cases, but actually it is something to be done when the case is negative, but also you still have the suspicion that the individual may have the disease, because PCR testing has high sensitivity, but say in Turkey, we had occasions that in like half of the cases, we couldn't show a positive test in an individual that we clinically sure that the individual has COVID-19. So in such cases, when the throat is not the location for the virus any longer, but virus is deep in your lungs, you may have PCR negativity. So in these occasions, we use some serological testing, especially for immunoglobulin A and M, to see and to confirm that it is a case. But in Turkey, we did something very recently. I was hoping to get the answers as of today, but I can only say what I know so far, but it needs to be confirmed by the written report of the Ministry of Health. Turkey conducted a survey, a sero survey in June, in a national representative sample of 154,000 individuals from nation, and they did PCR testing and serological testing simultaneously to check what is the actual identification rate of acute infection, active cases, and those who passed the infection. So what we got is we have 2 per thousand of active infection based on the PCR testing, and we have 8 per thousand of those individuals who test infection. Of course, there's a possibility, as Yanis mentioned, that some of the antibody testing results become negative in time, but still this was good for us to understand that we are far away from herd immunity. We have only like less than 1% of immunity, if there is any. So this kind of serological testing, I assume, is important only if you want to make sure that the individual is immune, and so that the person, like a health worker, can work, can go back to work, taking the risk. But otherwise, I guess serological testing is not a necessity to confirm acute cases unless you need to use it for herd immunity and how close you are to herd immunity.
Thank you, Professor Banu. Özge, one final question before we close.
Yes, please. This is actually my question to all our speakers. So starting with the pandemic, we started to see a lot of numbers and graphics all around media, on TV news, newspapers, and social media. But we also see that in many places, these figures and graphs can be very difficult to understand for many people. So how do you think we can make these epidemiological data more easy to understand for all people? Do you think, are there lessons learned for epidemiology experts themselves? So maybe, you know, if you have like short answers, thank you so much.
Certainly. I have a short answer to that, and that is that there are evidence-based design techniques that can be used in order to make more clear data visualizations that ensure that people understand the information better than they would otherwise. One of my favorites is a checklist by Dr. Stephanie Evergreen. Participants can look up the Evergreen data visualization checklist. All the items on that checklist are essentially from have a strong basis of evidence. And there are a lot of similarities to the CDC's Clear Communication Index, which focuses on developing written and visual public health communication behavior change information. So my answer is we can rely on evidence-based guidance. We should and can implement that guidance in order to make our data visualization clearer and more understandable.
Thank you. Corinne?
Yeah, I would say if you can, hire a data communication person because they're very helpful, or a data visualization communication person. But just from my experience, simplicity. If there's one word answer to that, it would be simplicity and consistency. So using the same words, the same terms, consistently and simply, I think is the most effective way in my experience.
Thank you so much. And Dr. Chakır?
Well, there are a whole lot of things to talk about this, but what I understood as an epidemiologist is that we have all been trained and teaching methodology, but we haven't been trained for any communication skills, not about visualization techniques, and not about how to convey messages to the public. I guess these needs to be emphasized more in schools and during job as well, because we need to convey message to the public, and we need to get their trust. So we cannot just say, well, you don't need masks. You know, it's not bad. You can go and get your do your vacation. You can do your wedding, but you know, you have to be separate, like 2 meters apart when you are dancing. I mean, these are not good stuff. The message needs to be honest, needs to be true. I mean, no matter whether to panic them or not, if they know that you are telling the truth, one day you say, you know, it's over, they will trust you. But for the time being, my observation from my surrounding is that no one even take it seriously, not even masking, or they are using masks for separate locations in their faces. I guess this is what we need to learn, how to convey our messages to the public in an honest way, and how to communicate with policymakers. We are not two sides of the coin. We are actually friends. We need to learn how to live together. I mean, okay, economy is important. We have our own budget. We need to socialize, but not for the time being. I mean, you may be lucky not to die, but you may be a killer of your neighbor or your father. I mean, we need to convey this message. I don't know how to do this, but we need to learn this. I mean, either through visual graphics or whatsoever, but all we need is to convey the right message in an honest way and consistent way. I mean, if one professor says something and the other professor says, oh no, don't care about it, I mean, then public, how to trust somebody? And it's true for scientists as well. We have 2 retractions from 2 most popular journals, Lancet and New England Journal of Medicine. If we don't trust into 2 journals, I mean, where can I trust and whom I can trust? So this is the most crucial thing. We should learn more about communication. We should know more about how to trust each other. I mean, there's no way other than trusting each other. We are all in the same boat. We will all die or survive, hopefully the second part.
All being the entire world.
Yeah.
Unprecedented times.
That's true.
So I think this will be a wonderful way to end this webinar. Effective strategies to communicate, not to go on a tangent, but obviously in the United States, we had a big issue very early on when we were told, the public, do not use masks. Masks are not protecting you. Don't take them away from the healthcare workers. And then 2 months later, masks are protecting you. You have to wear masks. And then we are now surprised why there are clear conflicts in certain areas where people are refusing to wear masks because they don't understand and they were told early on not to. And then, you know, not everybody in every level of the political spectrum is wearing them as well, just to confuse people even more. So clear communication, unified message, and obviously based on science. I want to thank our 3 wonderful panelists, Dr. Thompson, Professor Banu, and Mr. Montesano, for your great presentations. I think we are all so much smarter now, understanding the role of data in fighting COVID-19. I want to thank my wonderful co-moderator, Dr. Özge Karadakaman, and of course also CGC Istanbul and CGC Rio. If you enjoyed this event today, we keep organizing events around COVID or other events related to health or the Sustainable Development Goals. Please go on the Columbia Global Center Istanbul website for events, and you can also join our website, which is csd.columbia.edu for the Center for Sustainable Development, and you will see all the events that we have planned. Thanks again to everyone, and have a wonderful day.
Thank you.